Yes, sir.
Hello. Please.
Good evening, everyone. So, welcome to Complex Coronary Intervention Series 8, Day 2. So, we are glad to have our expert panelists today. So, we have Dr. Sugro Banerjee, sir, the Senior Consultant Intervention Cardiologist from Apollo Multispeciality Hospital, Kolkata. We have Dr. Dilip Ratnani, sir. He is HOD and Chief of Cath Lab at Sri Shankaracharya Institute, Bhilai. We have Dr. Manojit Lodha, sir, from Ramakrishna Hospital, Kolkata. And we have Dr. Adile, sir. He is the Director and Senior Intervention Cardiologist from Sankalp Hospital, Raipur. So in case presentation, first case will be from Dr. Dhananjay Kumar, sir. So I would request Dr. Dhananjay Kumar, sir, he's from Patna, to share his screen and start his presentation.
Good evening, expert panelists, respected speakers. Is my screen is visible there?
Yes. Okay.
So this 55-year male presented in our cardiac OPD, cardiac emergency at 10 p.m. with chest pain of 1 hour, and ECG was suggestive of lateral wall MI. He is non-hypertensive, non-smoker. He was non-diabetic by history, but he was hyperglycemic during the course of hospitalization. He had history of acute myocardial infarction in 2004 at the age of 33 years, and for which he had been stented to LAD and RCA. LAD with a bare metal stent of 2.5 into 33 mm and RCA with 3.5 into 23 mm, both bare metal stent. And we immediately took him to the cath lab, and this was his NGO. High OM was thrombotically occluded, and the LAD. LAD. There was in situ restenosis, a stent restenosis of significant level. The left system is giving retrograde to RCA up to proximal part of the stent, distal part of the stent. Yeah, up to the distal end of the stent. And RCA is totally occluded from the proximal part, totally occluded from the. So we did his primary PCI of 5 OM. Direct stenting with 2.75 15 Giants Expedition stent, and kept him for 48 hours. After 48 hours, we have two options: either to switch for a hybrid approach and send the patient to CTVS surgeon, or try at least for the RCA. If succeeded, then we will try for LAD. That was the plan. So we decided to go with the RCA. We took filter XT wire with some difficulty. It crossed the lesion. It crossed the lesion, and by sequential pre-dilatation with 1.25, 1.5 to 2.5, and high pressure non-compliant balloon at a stented side, we were able to achieve this Yeah, this was the flow. We exchanged the wire with the BMW, and we took the first IBUS run. I'm showing it separately because of some technical issue. My PPT is not working, so I'm showing it separately. So this was the first IBUS run. We took only a stented part. So this was the whole stented part was significantly re-stenosed with fibrous plaque, and the proximal end of the stent was significantly most critically stenosed. So we decided to, yeah, this was the most critical stenosis part. So we decided to give cutting balloon in the cutting balloon to this segment, and after that we will see. So giving cutting balloon, and after cutting balloon flextrom 2.5 into 10 and post dilatation with 3.5 NC at higher pressure. But during this procedure, the proximal part of the RCA get thrombosed and totally occluded. So we decided to put a stent in the proximal part first, and thereafter we will tackle the ISR section. So we put first 3.5 into 38 mm Giants Expedition stent in the proximal part, overlapping the distal older stent 1 to 2 stent assert, and after that another 4 into, yeah, another 4 into 23 mm Giants Expedition in the proximal part, both inflated up to the nominal pressure, and then took another IVUS run to see what happened after the flextrum cutting. So even after 2.5 flextrum, there was still a high chunk of fibrosed part, fibrosed plaque there. So we decided to give a 3.5 flextrum balloon. So this was the IVUS after the first 14 balloon. That is, in distal portion, somehow the plaque has been compressed, but in the proximal end, it was still there. And the proximal end of the stented, older stent was still critically stenosed. This was the, yeah, this was the proximal end. This is the proximal end. So it is still critically stenosed. So gave him a 3.5 flexon, and after 3.5 flextrum and high pressure NC ballooning, yeah, this was the result. And this show even at the most critically stenosed part, the plaque burden was less than 40%. So we decided to, yeah, left it as such without giving any stent there to increase the metal burden. So this was the final outcome after that. Yeah, due to thrombosis, thrombus migrated to the distal part. The PLV is not visible here. We gave intracoronary sodium nitroprusside with punctured balloon, and this is the final outcome of RCA. This is the final outcome of RCA. Yeah, This is the final outcome of RCA. Now we move to LAD wired with BMW. Give high pressure. Took a IVUS run first, and there was again fibrous plaque there with high plaque burden. So we gave 2.5 flexdome initially and post dilated at the higher pressure. Even after the 2.5 flexdome, again here the plaque burden is still there. So we decided to give the 3.5 cutting balloon and sequentially dilated to 3.5 and with a 3.5 NC balloon at very high pressure 24, 26. So after that, this was the result in LAT. Plaque burden here also, plaque burden is less than 40%, even less than 30% was there in LAD. So initially we have decided to give drug-coated balloon in LAD and RCA, but the cost of the procedure was so much so. And patient was not ready. Patient was from ESI something, so we didn't give him drug-coated balloon and neither any stent. So this was the patient. Now about 4 to 5 months has been crossed, and patient is doing well with dual antiplatelet with ticagrelor, ecosprin, and rosuvastatin of 40 milligrams. Hope so patient will do well. Thank you, sir. This was my presentation.
Nice presentation, and result was excellent. I'll request Dr. Ratnani sir and Lodha sir, please have a comments about. Hello.
Yeah, this is
Dr. Subbabraji saying things. Sir, please,
no,
sir.
that's fine. I mean, anyone can start. I think Dr. Lodha.
Right, sir. No, sir.
Yeah.
Continue, sir, please.
No, okay. No, I was just going to say this was a very nice case, very well done. The RCA. I just had one question about the RCA. So the RCA proximal part got occluded, right? So what was the cause for it? Do you think it was a thrombus or was it a dissection flap which caused the proximal occlusion?
It was a dissection. I don't think it is a thrombus.
No, I don't think so. Yeah. And later you had some thrombus occluding the distal part of it, distal part of the RCA. So where did the thrombus come from? That's another question which I had.
Sir, Dr. Dhananjay, I think disconnected.
Right. Okay. I
So
think
he's
so.
reconnecting. He's reconnecting, sir.
Okay. Okay. Yeah. So, well, we can, yeah. So we can discuss while he's reconnecting. We can discuss among ourselves as well. So, Dr. Lodha, yeah, you also asked some question.
No, I was not asking sir any questions. I also think that because there was some thrombus, so was ACT was done during the procedure or not?
That was my question as well.
So,
Because
He has not mentioned actually. He has not mentioned about the ACT and about the procedure time, how much heparin actually he has given. But procedure, according to us, it is a very long time procedure, not less than 3 hours procedure. How much time it is taken by the because I was wire crossing against stent, proximal part thrombus, dissected.
And the cause for restenosis, what was the cause? I mean, it was just new intimal proliferation, or was the stent adequately expanded? So I couldn't actually, that was something I thought of asking also. In fact, with ISR, I always find OCT more helpful. It gives a better image. Of course, you may not have it available in all places.
Exactly. At that time, it was very tough also to comment about this. Adile, what is your comment?
So while he's rejoining, Dr. Dhananjay is rejoining, any other comment on the case?
Sir, my comment is, suppose you will, after primary PTCA to L6, and patient can be kept for medical management also. And second thing is, without ballooning, without export catheter, putting a direct stent in L6, in primary PTCA, sir, what is your experience? Last day study also we have discussing this thing. Without seeing the distal vessel, what is your comment about? Now many operators are putting a stent directly without without pre-dilating, without using of export. What is your comment, sir?
I can tell you what I think. What I normally do, I first put in the wire and see how much thrombus is there. Whatever is said, like if I find there's a lot of thrombus, I use the export catheter. So the data says like, nowadays you don't have to use it routinely. That's true. But at the same time, if there's a lot of thrombus, I would use an export catheter. Now coming to direct stenting, if there's a lot of thrombus and I find that maybe that artery, that could be a fibrotic lesion, maybe that I may not be it's quite narrow, I may not be able to open the artery just with the direct stent, then I think it's better to first predilate and then go for stenting. But in some cases where I think that the rest of the arteries look normal, it is most likely a plaque rupture, should be a very soft thrombotic lesion, then we can go ahead with the direct stenting. So that's what I normally do. But yeah, I would also like to have others' opinion on this.
Lodha, sir, what is your?
I think if we can see the it also depends whether we can see the distal landing zone properly or not. If the distal vessel is not visible, then probably I don't go for the direct stenting. But if the distal landing zone is good, and if we think that the lesion is, as sir said, this is if the other vessels are okay and it doesn't, and the patient doesn't have a long history of diabetes or like that, where you don't expect a very thrombotic, a very fibrotic lesion or calcified lesion, then you can go ahead with the direct stent. Otherwise, I do prefer to go with the ballooning first and then put a stent.
No, sir. Just my question is: suppose you are having a lesion is come from the proximal part, you are not able to see the distally. To choice of the stent, to length of the stent, and what actually just because after wiring also there is no flow. So what is you are not able to see the distal lesion? Then what is your comments? Because many.
Then I usually go with the export catheter.
But no, sir, many that's why I want to comment from the others also. What is others comments? Because many operators now started doing this type of primary.
No. Then how will you decide what will be the length of the stent and what will be the diameter of the stent?
That's why I'm asking to the comment.
Dr. Bhanja.
Sir.
Actually, I do not agree with the concept that if you are not seeing the landing zone and directly putting the stent, it is sometimes very, very hazardous. Your wire may be in a small vessel, maybe it is a 1 mm vessel and you are dilating 3 mm stent. You never know what is the distal area dimension. And secondly, always in primary angioplasty.
Comments, sir. What is your experience?
I usually do export catheter. I use lot of thrombus extraction first, and after seeing clearly the distal vessel, then only putting the stent. And it helps me in preventing no flow phenomena and slow flow phenomena. And usually, whenever slow flow or no flow is there, nitroprusside do wonders if you give it through thrombus extraction catheter or through where he did like used a rupture balloon. Sorry, Dr. Bhanja, I'll have to leave because some urgent primary angioplasty is
Okay,
there.
sir. Thank you.
So
Thank you,
hope
sir.
to see you soon. Thank you.
I think you are in cath lab also. Thank you.
Yes, yes, yes.
Thank you. Thank you. Okay.
Yeah, I was just going to say, like, see, if there's a really lot of thrombus in that artery, we can't see the distal segment, and I'll be really very reluctant to put in a stent because that stent would get thrombused. So I would rather first want to secure the flow well and then only go with stenting. I don't know what people do, but I think I would be a little bit concerned just putting a stent in a lot of thrombotic milieu without really being able to see where my stent is landing.
That's what I'm saying. Sir. Expectant putting a stent expectantly that it will bring you the telemetry flow is not a good idea. Without seeing the distal flow, without establishing the flow, how can we put a stent? That is probably not very justified.
Yeah.
So I want to comment something.
Sure.
Sir, after wiring, sir, there was a distal TME2 flow and the distal landing zone was visible. That's why I put it the stent directly without pre-dilating this.
No, actually, it is not to you. It
was not in your case.
Yeah.
Was
Yes,
commenting.
Yeah. Okay, sorry, I was not there, so that's why.
Just general discussion.
Yeah. Sir, many a time, even after ballooning and even after daughtering, there is no distal flow. Then what happen? What will I am just a beginner. So what to do after that? Even after daughtering, even after pre-dilatation with a 1.5 balloon, there is no distal flow. Then what to do? Because definitely there after dilating with a higher size balloon, in 90% of cases we get slow flow or no flow phenomenon or embolization, distal embolization of thrombus. So the outcome is totally different. Initially I used to do daughtering or dilatation with the 2.5 balloon or 2 balloon. Now I am using either, even if a slight distal zone is there and I can deploy the stent there, I started deploying the stent and kept it as such without post dilating the stent and retaking the patient 2 days later and post dilating. This is giving a better result now. So in last 1 year I did about 300 or 400 primaries. I have just passed last year. So if during 1 year I have just experienced this thing, I don't know, sir. I want to learn from you people.
Any comments?
Sir, actually, just I want to say one thing. If if you left system, I think in LED lesion, if you want to do primary, if there is a stump, I think you should use at least export catheter if possible for it, if it is easy for you. And if you are not getting flow distally, then you can use adenosine or nitroprusside. Actually, I am frequently using adenosine in cutting balloon. The result is excellent to get the TME3 flow. And usually I used to use maximum patients in export catheter. And right-sided, if you have a temporary, then only you can give adenosine. Otherwise, in adenosine is very good drug for left systems, basically LED.
See, to answer that question, I think this is a situation which Dr. Dhananjay asked, like we come across at times. Say it's an LED where the lesion was a long lesion, say there was a proximal segment which was narrowed. We have ballooned it has opened, but a lot of thrombus and the distal part is not, still occluded. We have tried adenosine and all, but still occluded. So the question is, if say from the distal or mid distal the LED is occluded and a proximal there is a lesion which you have opened it, so do you stent the proximal part and leave the distal like that, or you don't do anything there? See, what I have done, I look at the artery, because if there say between the proximal stenosis segment and the distal segment which is not visible, if there are other diagonals which are actually coming out from there, then I would stent the artery, because then I know there is a place for outflow of the blood. But if it's an artery which is thrombosed or not visible, and even if I stent, then there's no place for the blood to flow, then I'm sure that stent would get thrombosed within very, very shortly. So in such cases, what I can do, I can open the proximal part of the artery, and later it may thrombose and it can cause even another problem. So in such cases, if that's not possible, using adenosine, using nitroprusside, then I will probably think about whether we should just balloon it and leave it rather than putting in a metal over there. But I would like to have your thoughts.
Doing balloon and leaving is better rather than putting a stand, because the chance of thrombosis will be very high. I think that is everyone is doing practice. Those seniors such practice like this, that just doing balloon, if you are getting repeated high thrombus burden, at least TB1, TB2 flow, you can leave and do the procedure later on. That is I think ideal for the patients also and the operator also.
Sure.
How come, sir, thrombosuction device helps in such situation? Sir, how much the thrombosuction device will help in such situation, sir?
Before you have to use the thrombosuction catheter before doing balloon pre-dilatation, then only it can help better.
And also, if it's very distal, then it may be difficult to actually take that, and it's not a very large vessel, it may be difficult to take the thrombosuction catheter down to the distal part.
Sometimes it's difficult to actually use this thrombosuction catheter without using balloon. So sometimes you have to do the balloon, then thrombosuction, and actually that thrombosuction catheter is not always helpful, because the cause of slow flow, or if you see the mechanism of slow flow or no reflow, they are it's a multi-dimensional actually. Sometimes platelet activation induced vasospasm or something else, so that is not always helpful. You see, for in such situation, first of all, the distal landing zone should be clear, and if there is a slow flow, say TB1 flow or TB2 flow, very slow flow, then just leave the lesion as it is. Put the patient on glycoprotein 2b3 inhibitors for 24 to 48 hours. Then again do the check angiogram, and then decide what to do now. In a slow flow condition or such a TB1 or 2 flow situation, if you deploy a stent, that will get thrombosis for sure. That is my
even in TB2, sir. Even in TB2, sir.
No, TB2 flow usually gets improved over the time. You can deploy a stent, but if there is no flow at all, or just the TB1 flow, just leave the what I think, what I practice actually.
In some cases, I think if you give everything, even give adenosine, if you give GP2B, whatever you will give, after that also you will not get flow, distal flow. In some cases, due to heavy thrombus.
That is true.
And basically, if patient's artery is aneurysmally dilated like ectatic vessels, then it is too tough to do procedures.
Sir, how often you use post-dilatation in primary cases, sir?
I think if it is, if it will not do, it will better. Post-dilatation, if there is significant stenosis is there, then you can go ahead. Otherwise, if you leave the patient, it will be better for you also and patients also, to prevent slow flow. Others, comment please.
See, I actually go for post-dilatation almost in all cases.
Even in primary PCI, sir?
In primary PCI also. I mean, I understand there is a risk also, but what I do not go to very high pressure, but at least I do some post-dilatation, because otherwise there may be a lot of thrombus, just outside your stent. And as they gradually get resolved, there may be stent malapposition also. So I do normally, Only exception would be there's too much of thrombus over there, and I really think there was a slow flow to start with, and then I would be then what I can do, I can bring this patient back and go after a few maybe probably after 24 hours or 48 hours, I can bring the patient back and go for a post dilatation. But usually in most cases I try to do the post dilatation even in primary. Do all of you actually do something else, like do you not do
I used to try to avoid, but whenever necessary I do, but usually in left system I usually basically LAD I try to avoid, because I have landed in many problems during post dilatation. So try to avoid as much as possible that unless otherwise long stands, and then and after taking stand Bs, if you'll see that stand is not a post, not uh, properly not inflated, then otherwise I try to avoid. But this is my clinical practice in LAD left system basically, right?
Actually, I also try to avoid post dilatation, or it sometimes it creates it is catastrophic for the patient. But if the stent is well expanded, then I don't do the post dilatation. But sometimes stent is well expanded, but there is some prolapse of plaque or thrombus through the stent struts. Then we sometimes we think that it's a under expanded stent, but actually it was the thrombus prolapse through that stent struts. So better, if it stent is well expanded, better to leave it and put him on glycoprotein 2 3 inhibitor.
but in that case probably you would need an IVAS at least, or probably in all cases.
Definitely.
If you have
Imaging is,
that, that's fine.
yes.
But without imaging, it's actually a bit difficult to really say whether that's the case.
I totally agree.
Particularly in cases where you are using long stent, sir, proximal system is quite bigger and the distal segment is quite smaller. That's why this disparity happens, and this required post dilatation.
So should we move on to the next case? I mean, how many cases do we have today?
Actually 3 cases are there. I think next case Rahul.
Sir, Dr. Gaurav sir and Dr. Sulabh sir both are not available. Dr. Gaurav sir is in primary, and Dr. Sulabh sir is out of due to some medical emergency. So,
Okay.
sir, can you share?
I will present one case, sir.
Yeah, kindly share your screen, sir.
Right. Okay.
Hello. Hello. Am I audible?
Yeah, you're audible, but you're actually echoing.
Actually, I'm just present a case which basically little different from the coronary. I'll just give you the brief history of the patients. This patient is a 40 years, 40 to 45-year young male. Actually, basically, he is a husband of our sister in charge OT. He presented to us with pain abdomen and workup by the gastroenterologist and the surgeon. Then they found to have pseudopancreatic cyst. Pseudopancreatic cyst was operated by the surgeon and patient was discharged. After discharge, second to third day of discharge, patient is complaining of fever with chill and rigor. And on examination, patient's neck is swollen and her neckline was there. They immediately we did Doppler, which show there is a healing defect in the internal jugular vein, which is extending to all territories. So they asked me what we should do for this patient, and the patient was an alcoholic. So I thought only just 3-4 days surgery is done, so we can keep it on Fondaparinux and almost patients and antibiotics. Patient was discharged without fever and kept on a NOAC. Then after discharge, again presented patients in emergency with GI bleed and shock. The patient was managed conservatively. He was upper GI endoscopy, no bleeding source. Patient managed with there about 10 to 12 blood transfusion, high dose inotropic support, ventilatory support. So then what to do? All the our actually hospital staffs, doctors are interested what next to do, because he is in our OT senior technician. And in the middle of the night at 12 o'clock, then everyone requested me to take the patient to the cath lab. No BP, only pressure support. I took the patients to the cath lab. Then I did a celiac angio. And celiac angio shows there is a contrast leak. First I tried with femoral, but I couldn't succeed. Then radial, I could not succeed. Then I tried to do it brachial. Then on brachial, I saw there is contrast leak in the splenic artery. So if you see, this is a massive hematoma. Total, this is a hematoma, and if you see, this is total because of hematoma. These are this scenario, and there is some contrast leak. I was confused what to do in this scenario. I'll show you next. You see, this is how basically it was a tamponade type picture. Then a brachial angiography, I'll show you how. You can see there is a contrast leak here. So I thought how I can without blood pressure is near about 50-60 in the monitors, what to do. I tried that. I thought I will take the guiding catheter to the basically to spleen and splenic artery, then I will at least give some gel form. But I could not succeed. In between 1 hour passed, and patient I saw that there is no flow in the splenic artery and hepatic artery. So I leave the procedure, and next day patient improved. There is some even after 2-3 days, patient was extubated, patient discharged. Then again, after 3-4 days, patient presented with upper GI bleed, massive upper GI bleed, again cardiogenic shock. Everyone, surgeon didn't do, he is not open the open. I asked you, please open and do whatever you best do. They told, no, there is so much neovascularization, it is not possible for us. Again, I took the patient to the cath lab. Then I did this, I saw there is a, again, some aneurysm type picture. I will just, I don't, then I rewire the splenic artery. And if you'll see, there is 2 wire. One is hepatic, common hepatic, another one is splenic artery, and 3 wires basically I put. Another one is in left gastric. Then I thought, now I have to do something. I am not able to cross the guiding inside. Then I thought I will put a cover stent there. You can see this is the cover stent. This is cover stent 2.7519. It was luckily crossed, and I inflate, but splenic artery is huge. You can see the aneurysm. This is the aneurysm. You can see the aneurysm and contrasting. And I inflate. Initially, I inflate because I thought it is not possible for me to take any post dilation valve, and my stent size was only 2.75 at that time. It was not available any further stents in my lab. So I gradually inflate the artery up to first up to 12, then even up to 22, 24. After that, there was no contrast leak. You can see just after patient discharge, patient was hemodynamically stable. Again, after 2 weeks, patient presented with the same symptoms. And at the time told, it is not possible for me. I can do anything. They did CT angiography, everything they did, but surgeon didn't want to open that because I didn't know why they don't. They are reluctant to do the surgery. Then I again took the patient to the lab. I finally, whatever artery at that time, splenic artery was occluded. There is not graft is totally occluded. You can see there is no, but there is so much neovascularization was there, and graft is occluded, and they want me to at least you occlude the other left gastric. So at that time, what I did, I again took the wire to the left gastric and embolized with gel form. That was my, after probably I took him 4 times to the lab, and then patient's hemodynamically stable, patient discharged. After 1.5 months, patient had some episodes happen in home and patient was died. But this procedure took at least 2 to 3 months in which surgeon didn't do anything. Whatever best for cardiologist, I did it. I peripheral stenting. So what is your comments? What should I should do for this?
Yeah, well, I think this is quite a difficult situation. I would have tried the same. I wonder, it must have been very difficult for you to take the cover stent across the tortuous splenic artery.
Exactly, sir.
So that's hell of a job. But again, I think the only, if it's really bleeding and we can't do anything, we can't close it with a cover stent, the only other option would have been to just thrombosed it. And I think that also eventually happened because the cover stent got thrombosed, so the artery got occluded altogether. But next, the question was, then why the patient was bleeding once again? Because
that I didn't know, sir, actually, because probably some neovascularization and because usually some comments are during pseudopancreatitis, infected pseudopancreatitis, there may be some small leak may be there.
Right. That's very interesting. I mean, at times previously they used to tag red blood cells with a.
I think I might I should have tried the first time during my first procedure. I should have put cover stand. What is your comment, sir? First time when I took the first time in the middle of the night, probably I should have tried with the cover stand in the first time. It was not in mind that whether I should put cover stand or not. I was in dilemma whether I should go ahead with cover stand or I would totally embolize the splenic artery.
No, first time what did you do? First time
First time actually, sir, I tried with wiring the splenic artery, but it was not possible for me to get in entry into the splenic artery.
Right.
I'm not able to. But next time when I tried that if I'm not entry, at least through the over the wire, I can took basically the cover stand.
Yeah. Now, the patient improves on it or improved on it his own.
No, what happened because of multiple trials, I think there is some thrombosis occluded the artery. I took multiple times wiring, multiple times guiding without heparin, only 1 or 2,000 heparin. It was in my mind. What is your experience, sir? Because I did 10-15 splenic artery embolized because some of the patients came for a huge splenomegaly and some portal hypotension. Some spot our gastroenterologist gave us some patients like splenic artery aneurysm, like this type of. But never I put this cover stent. This was my first cover stent in the splenic artery.
Well, I may not be the best person to comment on this because I have never actually done anything on the splenic artery. So maybe I would ask someone else to give the opinion. Because this is done normally by our intervention radiologist in our hospital, so we don't ever get any chance to do it.
Exactly. We don't have intervention radiologist.
Basically, it's a case of interventional radiologist, but you tried and did the case. What I think, maybe you can have deployed the cover stent during your first procedure only, and if it's still bleeding and bleeding, then it's better to thrombose that artery.
Yeah, I think if it's bleeding and we can't control the bleeding, then you thrombose the artery, and then the surgeon would take care of the later consequences.
And later on, what happens, sir? It is very difficult to comment. Later on, if you see, I put the cover stent, but stent has already occluded. There is no flow to the splenic artery automatically probably because of no antiplatelets.
But then also the patient was bleeding, so that's
after that also bleeding. That was pretty difficult to comment. But definitely in my first celiac angio, there is classical contrast leak was there from the splenic artery. And splenic, you can see this how this splenic aneurysm was there.
Have you investigated the patient for that bleeding diastasis profile?
Yes, there was no bleeding. It was normal. Bleeding was even CT shows there is some small contrast leak was there.
What do you think? Why it was so?
That my opinion, probably because of infected pancreatic pseudopancreatic cyst, probably have a neovascularization, which probably. But being a cardiologist, we have to do all these procedures in the middle of the night. Everyone with us.
This is an uncommon case. Intervention radiologists are involved.
To get intervention radiologist is very difficult in small places.
Yeah, I can understand.
And I put 3 ORs. It was also, I thought how I will go 3 ORs in 6 French catheters. And basically, sir, what is my experience? It is from my what is the summarize? I think it is always if you will do a peripheral, basically celiac or superior mesenteric or inferior mesenteric artery, basically we should go from brachial is very good. Its approach is very good. You can easily hook the artery because
Yes.
maximum.
Yes, I have done several procedures through brachial route only.
So even femoral, it is very difficult to hook the artery.
Yes.
Because you are also doing many peripheral cases. Lodha sir?
I am not doing a lot of peripherals. Actually, apart from renal artery embolism in 2-3 cases where there was post-piscinal, there was bleed, persistent hematuria. In those cases, I have coiled it. Otherwise, these things are done by intervention radiologist.
But I think some nephrologist can give you some cases after renal biopsy.
Post-piscinal patients, I have done some patients who were with persistent hematuria. They were presented to us. So in those cases, we have done the coiling basically. Renal artery coiling is not a difficult task. It is an easy procedure.
No, intervention radiologists are doing the selected arteries.
Yes.
They are going to throw selected because as a cardiologist, you can do totally operate the artery. They usually go to the selected. Rahul, any other case is there?
Sir, as both the speakers are not available, we can conclude the session, sir.
Okay.
So, I would like to thank all our expert panelists, Dr. Surya Banerjee sir, for taking time and joining this webinar. Dr. Adile sir, thank you very much for your contribution to this webinar. Dr. Ratnani sir, thank you very much. You joined with along with your primary plasty. Dr. Manojit Lodha sir, thank you very much. Dr. Dhanajay sir, very nice case. You have demonstrated IVUS guided PTCA. And Dr. Bhanja sir, as usual, you are always there with us whenever there is a presentation. So thank you very much, doctors, for joining late evening. Thank you very much. Good night. Stay safe, stay healthy, sir.